Hello everyone. Today, it's my pleasure to introduce the article Expert Consensus on the Diagnosis and Treatment of Malignant Mesothelioma. The Tunica Vaginalis Testis. Malignant mesothelioma of the Tunica Vaginalis Testis. MMTVT is a rare malignancy originating from mesothelial cells of the testicular tunica vaginalis, accounting for 0.3% to 5% of all malignant mesotheliomas. Its low incidence and diagnostic pose significant challenges in clinical practice. This expert consensus is the world's first clinical diagnostic and therapeutic guideline for MMTVT, aiming to standardize the differences in diagnosis and treatment caused by the lack of relevant guidelines. Given the pathogenic risk of asbestos for mesothelioma, individuals with a history of occupational asbestos exposure, especially patients aged 60 to 80 years who present with hydrocele or painless and progressive enlargement of the scrotum, should undergo relevant exclusionary tests and examinations. For patients of any age, particularly 60 to 80 years, with a history of prolonged occupational asbestos exposure or residence in high-risk areas, presenting with hydrocele, scrotalmus, inguinal hernia, varicocele, or testicular torsion, MMTVT-specific evaluations are recommended to exclude malignancy. Recommended. The diagnosis of MMTVT is divided into clinical diagnosis, imaging diagnosis, and pathology and molecular diagnosis.
Imaging strongly recommended. Ultrasonography is primary for screening testicular tunica vaginalis lesions. CT/MRI clarifies tumor extent, e.g. retroperitoneal lymph node metastasis and AIDS. Preoperative planning. PET-CT assesses dissemination, stage treatment response. Pathology strongly recommended. Histopathology is MMTVT's diagnostic gold standard. Subtypes: epitheliate, sarcomatoid, biphasic. At least 3 mesothelial markers, e.g. calretinin, CK56, WT1R for diagnosis. Genetic sequencing recommended. Targeted whole genome sequencing in recurrent MMTVT clarifies recurrence mechanisms and informs novel therapies. Multidisciplinary consultation strongly recommended. Due to MMTVT's complex clinical diagnosis, radiology, pathology, surgery, oncology consultation minimizes misdiagnosis. Missed diagnosis.
At present, the goal of surgical treatment for MMTVT is to resect all grossly visible or palpable tumors. Retrospective case analyses have shown that surgical approaches and patients' clinical characteristics are closely associated with prognosis. Meanwhile, tumor size 49 mm is significantly associated with metastasis in MMTVT patients. Note: corrected MTVT to MMTVT for consistency. Consensus 6. Patient age, underlying physical condition, tumor stage, and surgical approach are important factors affecting prognosis. For patients with local lesions and no surgical contraindications, surgical resection can be selected. For patients with suspected lymph node metastasis, contrast-enhanced abdominal CT is recommended, and lymph node dissection should be performed if necessary. Consensus 7. Treatment methods for locally recurrent MMTVT have not been standardized. At present, there is insufficient data to recommend or oppose adjuvant systemic chemotherapy or radiotherapy. The decision to administer chemoradiotherapy can be made based on patient's general condition, age, pathological features, and the presence of high-risk factors. Postoperative radiochemotherapy should be individualized. High-risk factors such as tumors greater than or equal to 49 mm recommend combined radiochemotherapy. First-line chemotherapy is platinum pemetrexed. Radiotherapy requires tailoring radiation fields and doses to tumor location and surgical findings. Due to high recurrence risk, follow every 3 months for 2 years clinical exam, CT, or retroperitoneal US, then annually until 5 years. Lifelong surveillance is advised for late recurrences. Strongly recommended. In summary, MMTVT is prone to misdiagnosis and underdiagnosis owing to its extremely low incidence and nonspecific clinical manifestations. For diagnosis and treatment, multidisciplinary team collaboration is strongly recommended to ACHI.